Hello friends, welcome to CardioCon 2023. Today I am going to discuss a topic which is really life-threatening and require immediate decision in terms of diagnosis and the management, and that is the diagnosis and the management of acute massive pulmonary embolism. Venous thromboembolism affect nearly 10 million people every year worldwide. And most significant subtypes are DVT and pulmonary embolism. DVT means the blood clot in the leg veins, and the pulmonary embolism when that leg veins clot migrate and travel to the heart and goes into the pulmonary artery, that is a pulmonary embolism. There are a number of risk factors predisposed to pulmonary embolism. This is a long list: the surgery, trauma, immobility, cancer. These are the main risk factors: pregnancy, obesity, iatrogenic like CVP line incision, stroke, fracture. These are the main risk factors which we see in our clinical practice. By 3 months, 14% of the patient with proximal DVT and 18% with PE will have died. It is more than a cancer and the traffic accident. The clinical presentation: in symptomatic DVT, approximately two-thirds of patients present with symptoms, and almost one-third patient present with symptoms in PE. Most patients with VTE may have both DVT and PE. Almost 50% of patients with proximal DVT, even though they don't have any symptoms of PE, but in the lung scan, we can find out that these patients have PE evidence. This is called as silent PE. Annual incidence of pulmonary embolism ranges between 23 to 69 cases per leg, and it is responsible almost 15% of the hospital death and 30% of the pregnancy and delivery death. Nearly 10% of patients who die of PE do so within 1 hour of onset of symptoms. So the time is also important. The decision making is also important because really high mortality rate. Most of the time, there is no specific sign and symptoms because these are not sensitive enough. The clinical suspicions largely remain unconfirmed due to the high mortality rate, and the silent P is also responsible, which is present almost in 50% of the DVT cases. Classification of P: massive, submassive, and low risk. If patient present with acute pulmonary embolism with sustained hypotension, blood pressure less than 90 for 15 minutes, or require inotropic support, pulselessness, profound bradycardia, and shock, considered massive PE. Submassive PE, blood pressure should be more than 90, but there is evidence of right ventricular dysfunction. And the low risk acute PE, absence of clinical markers of adverse prognosis, that is related to massive and submassive PE. Now, the indicator of RV dysfunction: the RV dilatation, elevated BNP and anti-pro-BNP, ECG changes like right bundle branch block, and typically T wave inversion in the first V1 to V3 leads. Indicator of myocardial necrosis, as in coronary, like elevated troponin. So, massive pulmonary embolism is the result of hypercoagulable state. If we go with virtual triad, there is disruption of the hemostatic balance, thrombin activation, formation of the thrombus, ultimately blockage of the vein, that is DVT. And that embolization of that clot goes to the lungs and the formation of pulmonary embolism. If patient is hemodynamically unstable, that causes acute massive pulmonary embolism. So, in pathophysiology, there is obstruction of the flow through the main pulmonary artery, increase afterload in the ventricle. In addition, there is mechanical obstruction of the RV, release of vasoactive mediator, thromboxane A2, serotonin, and resulted in pulmonary vasoconstriction, increased pulmonary vascular resistance. Resultant increase in RV wall tension, displacement of the interventricular septum to the left, and impaired left ventricular filling, and if untreated, RV outflow obstruction. So, The final goal in the management of P, there should be prevention of the death, reduce the chances of recurrent embolic event, and minimize the long-term morbidity. So first step, we have to suspect, because there is history and clinical scenario is very important. If any suspicion is there are certain criteria like Geneva and Wells rule can use and clarify that, and then diagnostic workup like D-dimer, ECG, echo, and then lastly CT pulmonary angio. After that, risk stratification, either patient is hemodynamically stable or not, RV dysfunction is there, and troponin levels. And after that, patient should be treated according to the risk stratification with anticoagulation and thrombolytic agent. Now coming to the case scenario, a 57-year-old male smoker, no significant past medical history, presented to the emergency department complaining of severe shortness of breath, and he reported that as he reached down to pick something, he suddenly was not able to catch his breath, felt lightheaded, and collapsed to the floor without any loss of consciousness. The associated symptoms included chest pain that was worse on the inspiration and diaphoresis. This is the classical typical history of acute pulmonary embolism. An initial assessment in the emergency department revealed blood pressure of 80 mmHg. He was in shock, heart rate of 132 beat per minute, tachycardia, and the respiratory rate of 40 per minute, tachypnea with an oxygen saturation of 80 breathing air. Pulmonary finding consisted of bilateral crackles at the bases, and his extremities were cool and cyanotic with weak peripheral pulses. Electrocardiogram shows sinus tachycardia. So this was the typical clinical scenario of pulmonary embolism. Now coming to symptoms, usually these are non-specific, severe dyspnea at rest, syncope, and even cardiac arrest. Maybe past medical history related to thromboembolism, tachycardia, tachypnea, hypotension, cyanosis, and there may be evidence of RV dysfunction, include distended neck veins, parasternal heave, accentuated pulmonary artery pulsation. And sometimes when you are suspecting, not sure about the pulmonary embolism, there are certain criteria like Geneva rules and the Wells rule may help in diagnosis or in suspicion of pulmonary embolism. In Wells score, there are certain points like history of previous P, heart rate more than 100, surgery in the last 4 weeks, hemoptysis, active cancer, signs of DVT, and there should not be any alternative diagnosis of P. And each point, if it is present, given one score, and if that scores more than 2, then there is high risk of pulmonary embolism. Similarly, similar kind of score, other than the one more criteria, they added that age more than 65 in Geneva, and if it scores more than 3 or more, then chances of P are very high. So now coming to the diagnosis, we should send D-dimer in each and every suspected patient of P, ECG for the right ventricular overload. X-ray mostly don't get any specific findings. Yeah, echo and tropi and BNP definitely may help. And lastly, the gold standard is CT pulmonary angio. And for the Doppler of the leg veins to find out the cause and source of the emboli. Now coming to the algorithm to diagnose the P. Once you suspected P on the basis of symptoms like dyspnea, chest pain, cough, syncope, and ordered chest X-ray, ECG, routine lab, D-dimer, and anti-pro-BNP. After that, you have to stratify the risk. If patient is in shock, pulseless, heart rate 40, if yes, then send the patient for CT pulmonary angio. If it is positive, then the treat as a massive pulmonary embolism. Or if CT pulmonary angio is not possible, then do echo. If you get findings of pulmonary embolism like RRV dilatations or in echo, and consider P and treat accordingly. If no, then that. If you are not suspecting, if you are suspecting but non-high risk P, like patient is not in shock, then assess clinical probability simplified Geneva score. If it is more than 2, then treat a considered P and send the patient for CT pulmonary angio. If score is less than 2, then pulmonary embolism exclusion score. If it is there, then send the D dimer. If it is positive, then again same way, advise CT pulmonary angio, and on the basis of finding, consider P. So this is the algorithm in diagnosis of pulmonary embolism. If patient is in shock, hypotension, it is high risk, and if it is not, then no risk. So shock is the criteria of high and low risk. In high risk category, hemodynamic instability is the only criteria. Other parameter like RV dysfunction, troponin positive, or NT-proBNP raised, all these fit into the intermediate category. And excluding all these things and suspecting pulmonary embolism, then it is a low risk pulmonary embolism. Now coming to the pulmonary embolism severity index. There are certain criteria, parameters like age, male, cancer, chronic heart failure, chronic pulmonary disease, pulse rate more than 110, BP less than 100, respiratory rate more than 30, temperature, altered mental status, saturation. According to that, if 0 point, there is 1% mortality risk. If point is more than 1, then more than 10% mortality in first 30 days. So this is the risk stratification criteria on basis of embolism severity index. Now coming to the treatment part, immediately patient should be on unfractionated heparin if it is a high risk patient, and then fibrinolysis is the should be done immediately. Low molecular weight heparin, yes, there is a role of low molecular heparin in intermediate to low risk category. And catheter directed thrombolysis, rarely used. Surgical thrombectomy once fibrinolysis fails. An IVC filter for when patient is contraindicated for anticoagulation. Anticoagulation in high risk P, anticoagulation with unfractionated heparin should be started without any delay. LMWH and fondaparinux is recommended for non-high risk P, as I told, and unfractionated heparin should be continued for at least 5 days, may be replaced by vitamin K antagonist only when targeted INR level achieved 2 consecutive days. Anticoagulation should be started at the earliest for the patient with intermediate or high clinical probability of P and having no contraindication to anticoagulation. Thrombolysis in acute P. The faster improvement in pulmonary obstruction, PA pressure, pulmonary vascular resistance in patient with P compared with unfractionated heparin alone. The improvement are accompanied by a reduction in RV dilatation on echocardiography. The greatest benefit observed when treatment is initiated within 48 hours of symptoms onset. Even though thrombolysis can be done till 14 days. A meta-analysis of thrombolysis trial that included patients with high-risk P indicated a significant reduction in combined outcome of mortality and recurrent P. Now the thrombolytic agent, only 3 agents are recommended, that alteplase, streptokinase and urokinase. RTPA dose is 100 mg over 2 hours, streptokinase 2.5 lakh bolus followed by 1 lakh infusion for 24 hours, and urokinase 4400 international unit per kg as a loading dose and followed by 4400 international unit per kg per hour for 24 hours. So according to the guideline, it is recommended that anticoagulation with unfractionated heparin, that is the class 1 indication, systemic thrombolytic therapy in high risk P, class 1, and surgical pulmonary embolectomy if thrombolysis fail, class 1 indication. Now coming to the alteplase, a thrombolytic agent, a recombinant human tissue type plasminogen activator that activates plasminogen directly to plasmin, lysfibrin as well as fibrinogen. It is approved for use in acute ischemic stroke, pulmonary embolism, and MI. The dose usually in more than 65 kg, total 100 milligram, among them and 10 milligram is given as a bolus and 90 milligram as an infusion. There are certain contraindication in any kind of thrombolytic therapy. Same is applicable here also. Now coming to the clinical evidence of alteplase in acute P. Can see there is it significantly lower the mortality compared to the heparin alone therapy in massive P, and that is the massive advantage. The efficacy of systemic thrombolysis that shows that P mortality and death that is statistically significant in terms of systemic thrombolysis compared to not thrombolysis, and it is more safe. When you compare with LT and tenecteplase and other thrombolytic agent, there is major bleeding and the intracranial bleeding or less with alteplase. So alteplase is more safe and effective in pulmonary embolism. The benefit of thrombolysis in pulmonary embolism, that is the PAMS2 trial, 36 patients with acute PE randomized in one group is received RTP and another one heparin alone, and followed immediately after termination of a study that showed reduction of the angiographic severity of PE and reduction of mean pulmonary artery pressure from 30 to 21, and increase in cardiac index from 2.1 to 2.4. Now, alteplase versus heparin in acute PE, and in this trial, more than 100 patients. And first group RTP was given, in the second heparin alone. The randomized double-blind trial that shows in the RTPA group, improvement of the RV function, reduction of the RV dimension, improvement of the pulmonary perfusion, and there is no PE recurrence. So, in thrombolysis, really help acutely as well as long-term benefit. The randomized control trial of RTP versus urokinase, and that is a clot lysis at 2 hours. Two principal endpoints: clot lysis at 2 hours as assessed by angiography, and the perfusion defect with the perfusion lung scanning. By 2 hours, 80% of RPA treated patients show clot lysis compared with 48% of urokinase treated patients. An improvement in lung scan reperfusion at 24 hours was identical in both the treatment group. So again, RTP is better in that terms. Effect of urokinase versus RTPA on total pulmonary resistance in acute massive pulmonary embolism. After 2 hours, total pulmonary resistance decreased by 22%, and in alteplase it is 36. So almost statistically, significant difference is there. The continuous monitoring of the pulmonary arterial pressure, cardiac index, and total pulmonary resistance reveal that these variables improve faster in alteplase group with persistently significant intergroup differences from 30 minutes to 4 hours. Now the third comparison between alteplase and the streptokinase, and that shows that there is an improvement in the right ejection fraction evolution and improvement in the pulmonary vascular resistance compared to the alteplase. So to summarize, one should suspect the P, that is the most earliest and important thing. Once you suspect if any likelihood of P, take the help of Geneva rule or Wells rule, and then start doing a diagnostic workup like the day dimer, ECG, CTPA, lastly before echo, after echo, and finally the risk stratification. Is patient is hemodynamically stable, RV dysfunction is there, troponin levels are increased or not, and after that treat accordingly with anticoagulation, thrombolytic therapy, and last option is the surgical thrombectomy. Thank you so much.